How are you? Good.
Was she cooperating or no?
No. No. I mean, I'm 90%, you know. Testing 1, 2, 3. Testing. Okay.
Well, both my kids didn't follow. One left Thursday, one left Friday. My kid that left Thursday is back already. He only had to attend the funeral, but she was my grandniece, so I was more concerned with her flying out than my youngest. Because my youngest wants to go see her dad for about a month. Okay. So I'm not happy with that. So she's still out there. I'm like, can you come home already? I know it's been less than a week since I shipped you off. It is, it really is, but sadly, everything's so expensive there. And I just have so many bad memories there that wasn't the place. Not the place. Not the place anymore. I mean, I spent 25 years there, so. Oh, really? Really, you were sea level, huh? Oh, I love it too. I love it too. Chalked out no snow. Never have to shovel that stuff. I mean, the last snowstorm that we got, it was up here. I had a migraine during it. So first off, I dug myself a house. I live 20 miles east of Denver, on the plains.
There we go. Okay.
Dig myself out, get myself all the way to the highway to find out the highway's closed.
Okay.
So when they reopened the highway and everything was cleared out, I went to the hospital for a migraine and a pinched nerve in my shoulder. Because
Okay. So testing. Can you guys in YouTube world hear me? If you can hear me, please tell me that you can hear me. Put something in the chat for me. Good. Yay. Okay. All right. I think I have some of this figured out for today, so we can start. It's always a good thing. I got 2 weeks off in between classes. My next one doesn't start until October 31st, and I'm going to be in here trying to figure all of this out. So wish me luck. Okay. See here. I'm up on the screen. All right. Does anybody have any questions on what you read over the weekend? Chapters 8 and 9. 8 was on nutrition, and it can get a little bit overwhelming. That it's a short chapter, but nutrition is a complex subject, and we really are what we eat. So it's can get a bit overwhelming. Chapter 8 can. You aren't responsible for knowing what diseases require which diets. I mean, that's realistically, that's a dietitian's arena. And nurses have to be familiar with it as well. CNAs need to be familiar with it as far as understanding that when you're passing out food trays, if you give the wrong tray to somebody, it can have serious physiological effects. So it's not just a matter of, well, you know, he doesn't like turkey sandwiches, it'll be all right. It's the fact that he needed a low sodium diet, and that was not low sodium. Does that make sense? Mm-hmm. It's also going to apply to you because as CNAs, we often select snacks for patients when they get a little peckish, a little hungry. And we usually give them a couple of options. Okay, do you want some graham crackers or some yogurt? You know, this is what we have here. What sounds good to you? Well, if the patient is on a specific diet, that really should impact the snacks that you're offering. If we've got somebody on a low sodium diet, we don't want to offer popcorn and pretzels. That's not a good solution to that. You would want to order or want to offer something that maybe has a little bit less sodium in it, like sugar-free Jell-O and graham crackers. You know, which one would you like? So It helps to understand how to read a nutrition label. It helps to understand that specific diets are ordered for specific reasons. And it helps to understand, I don't know why you were doing what you're doing. It helps to understand what our responsibility is in all of this. But, you know, nobody's going to ask you on the state exam, your patient has end-stage renal failure, what would an appropriate diet be for this individual? That the appropriate diet would be ask the nurse. Okay, does that make sense? There's going to be a lot of complexities to this. Now, I can tell you all day long that if a patient's on end-stage renal failure, we're probably going to have them on a low protein diet because their kidneys aren't going to be able to filter that effectively. End-stage renal patients have kidneys that kind of look like Swiss cheese, like things that your kidneys would catch and put back in the system. Their kidneys just let go because the filter is just, the holes are too big. So that can be problematic for patients. So, but a lot of end-stage renal patients also have blood pressure issues because they can't excrete the fluid well. So that becomes a real tightrope. And that's really why we need those nurses to help us plan effectively diets and snacks and things like that, because they have to look at everything. And then on top of that, if the patient has pancreatitis, that's going to affect what we're offering. So, you know, it's kind of like layer upon layer of complexity. And that's why CNAs aren't responsible for knowing any of that. Because chances are you're going to get a little bit of knowledge, make a decision, and it's going to be the wrong one. Because you don't, not because you're not capable, it's because you don't have all the information. Does that make sense? How many guys have a refrigerator at home? All right, well, I have a refrigerator and it's only 2 years old. It's still relatively new and it was having a problem. So I called up the repair people and I figured, well, they'll be able to fix it's a refrigerator. It's what they do, right? So there were a million questions. Well, what kind of refrigerator is it? Well, what is the brand? What is the model? So I have to answer all of these questions because it's going to depend. The answers to my questions will affect the part they're going to order. So if I give them a Z instead of a 2, that can affect the part that they order. It can also affect what they determine the problem is. Could be a gasket, could be a compressor, could be the door wasn't closed all the way, right? There's a lot of variables there that they have to consider. Well, if we can get that complex with a refrigerator, imagine a human body. So every single little itty bitty detail is going to affect the final answer. Does that make sense? And because CNAs don't always know every single little itty bitty detail, you may recommend a gasket when it really is the compressor. Okay, good. All right, so let me get your scores for 8 and 9. So, Sandy?
Chapter 8, I missed 1. Chapter 9, I missed 1.
Very good. Chloe? Okay, that's fine. Do you happen to have 6 and 7 for me? Okay, that's okay. Melissa? Denisely? Okay, that's okay. Amanda? Thank you. Dawn? Whitney? She'll be in later. Karen? Okay. Soraya, Valerie.
8, none, and 59.
Okay, very good. All right. So let's go over body positions really quick. This was in chapter 9, and I just want to review this with you because this is something that you're going to see in a clinical setting. We tend to, when we're talking to one another in medicine, we tend to use medical terms a lot. So if I asked you to put the patient in a Fowler's position because they're having difficulty breathing, you need to know what that is. Or if I ask you to make sure the patient is lying supine for 4 hours after a lumbar puncture, you need to know what that is. So there are basic body positions that, and there's not that many of them, but Fowler's is a big one. Fowler's is sitting up, right? Head of the bed up. Semi-Fowler's, like the name would suggest, is sitting up a little. Okay. But Fowler's truly means sitting up. So what kind of skills would we need a Fowler's position for? Mouth care. Yep. Denture care. Okay. Semi-Fowler's is okay for dressing, you know, to put their clothing on if you want to do that, that's fine. But you won't see that on the care plan for the test, right? They're not going to tell you to put the patient up in Fowler's position because they expect you to know that that's a requirement. So you're not going to see that term on the care plans for the test, but you do need to know what they are because they may show up on the written test. Now, I have crazy little memory tricks that I use to help me with these terms. And I developed these way, 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 way back in the Stone Ages when I went to nursing school. But another word for fowl is chicken, right? Bird, you know, fowl. So Fowler's is a position you have to be in to eat chicken. Okay, does that make sense? So a way to remember, Fowler's is sitting up because I want chicken, especially if it's fried. Now, Sims is a position where the patient is laying kind of half on their side, half on their stomach, kind of that in between. Left leg up, so knee up. So laying on the left side, kind of half on their tummy, left knee up, right leg straight. For me, that's my sleeping position. That's how I sleep. So Sims sleeping. That's how I remember that. Prone is posterior up. Supine is on your spine. And lateral just means on your side. So if you remember those 5, you'll be in good shape. Right, right. Sims is specific to, left leg drawn up. Now, the reason is that we use that position for enemas. And we want the body, because the way the intestines run, we want the body positioned so that when we instill an enema, it doesn't all come rushing right back out. So that's why the Sims position is used. It's also used for colonoscopies, you know, other rectal type procedures. But you'll also see it used for other things. For instance, sometimes if they have a particularly difficult patient to put an epidural in, they'll get them in a Sims position, especially women that are about to give birth, you know, big bellies, because they can't always bend over enough to elongate those intervertebral spaces. So sometimes you'll have them on a Sims position, kind of curled a little bit. So you'll see this used in lots of applications, but you need to know it's generally on the left side. Now, if it's right side, it'll actually say position the patient on the right side. But Sims is specific to left. Make sense? So that's really the big thing out of chapter 9. The other thing that I want you to be aware of with chapter 9 is something we've been talking about throughout this whole program. I talked about it on day 1, actually hour 1, that patients are encouraged to do the things they can do on their own. So we only do things for patients if they can't. So if they can brush their own teeth, they're going to brush their own teeth. We're only going to get involved if they can't. If they feed themselves, we're going to let them feed themselves. We're only going to get involved if they can't. And that's probably the wrong terminology. I'm not going to let an adult do anything. I'm going to encourage them to do the things they can do. It's not a permission thing. So that was the wrong term. I don't let you go to the bathroom. You're an adult. You're going to go regardless of what I have to say about it. Right. So, so kind of keep that terminology in mind. Try not to use terminology that puts you in a superior position over the patient. We're there to assist. But chapter 9 is all about useful tools and gadgets and techniques that we can use to allow our patients or encourage our patients to be as independent as possible. So somebody with Parkinson's disease may have trouble drinking or eating soup because of shaking. And whatever you get on that spoon isn't going to make it all the way up to the mouth, because with the shaking, whatever's on the spoon will come off. So they actually have utensils that remain still even when the hand is shaking. It counterbalances. So the spoon would only move about this much when the hand is doing this. It's almost like a gimbal on a camera. It counterbalances and keeps it steady. Well, that would be awesome for somebody with Parkinson's to maintain their independence, even when trying to eat things that are traditionally a little bit more difficult to eat. Does that make sense? They have long shoe horns that help you put your shoes on without having to bend. That could be helpful as well. Remember that independence is essential for good mental health, but also good physical health, because the more that we do ourselves, the less atrophy that we get in our muscles and the less joint mobility issues we experience. So chapter 9 is all about how to, what to expect. Now, CNAs don't decide to use any of this. Who makes those decisions? And in this case, they're going to defer to physical and occupational therapy. So I actually am not going to make any of those decisions myself, not my area of expertise. So I'll be calling up the occupational therapist and say, hey, Henry's having trouble eating soup. He has advanced Parkinson's. What can we do here? Good. And they're up to date with all the latest and greatest gadgets. I always look at occupational therapy like Inspector Gadget. I mean, they've got some really cool things that they can use. I don't know all of them, have no idea, because I'm not an occupational therapist. So I'm going to refer to them. Good? Does that make sense? Now, what I do need you to do as a CNA is to notify me when you notice the patient is struggling somewhere. Because I'm not going to know that they can't button their buttons anymore, or that they can't zip their zippers anymore, or they're having trouble putting their socks on. I'm not in there for that. I don't get to see that part of their daily life. So I need you to let me know when that becomes an issue, so I can get on the phone with the occupational therapist and the doctor, and we can get some things ordered to make sure that this patient truly is being able to live their best life. Good? All right, so you have one chapter to go in homework, just one. So the blue book, you're going to go read chapter 10 tonight. And then when you come back on Wednesday, you're going to bring your blue book in with you. I'm going to collect them. And chapter 10 is employability, stress management. Don't forget to care for you while you're caring for others. Good employment traits, things that they're looking for. Now, 2 weeks ago on my live, I don't know if anybody caught it, but I actually had a 30-minute lesson on ways to present yourself well in an interview. What should you wear? What questions should you ask? What are some things that they're looking for? Where do you find a job in healthcare? So I have a whole 30-minute lesson on that. If you go watch my lives from 2 weeks ago, it'll cover it. I'll cover some of it with you in class, but I'm probably not going to give you the entire lecture. So you may want to go watch that. Good? Questions on that? So you're going to read chapter 10. It's a short chapter. The book ends you super easy. So short chapter, easy material. Bring your blue books back on Wednesday. We're going to take a class photo too. So make sure that you're whatever you need to do for a class photo, right? I tried to remind you because otherwise I get people going, oh my gosh, I didn't do my hair. Employers do look at our class photos, and a lot of times they'll post right on there, hey, we're hiring, come see us. Usually I have an employer come in on graduation day to basically recruit you. I've got a whole list of employers that are literally banging down the door trying to get in here. I'm not letting anybody in for this class just because we have new technology and I haven't figured out my liability aspect for all of that. And so I'm not going to have anybody come in and talk to you guys. But on my website, foryourcna.com, under after certification, up at the top, you got CNA training, online class, testing, and then after certification. I have a local jobs listing there. So if you click on that, here in Hernando County, I have every hospital, every nursing home, every assisted living facility, every home care agency, every other category like a pediatric daycare or mental health center. So walk-in clinics, all kinds of stuff up there. And if you click on the name of the facility, it takes you right to their website, the hiring page on their website where the jobs are listed. I've done all the work for you guys. All you have to do is click it and apply. Okay. So I've done it all the work for you. And everybody right now is hiring. Everybody. First of all, we are in a CNA shortage. You've heard me talk about that. But in Florida, we have something called season. And a lot of people don't know this if you're not in medical, but we have season. Season goes from October to April, and it's snowbird season. When all of the people from up north in Canada come to Florida, because they don't want to be in that cold weather. We know why. Remember, they've lost their wetsuit. So they come to Florida, but they bring all of their illnesses with them. So where we had a whole bunch of elderly patients to take care of, now that has doubled for 6 months of the year. And we are in October. So every place is hiring because of this new influx of patients. Season used to be a whole lot more than it is. Now it seems like everybody came and stayed after COVID. It's like we're still seeing an influx, but it's not as pronounced as it was 3-4 years ago. Because we are kind of staying at a steady high rate. I'm not real sure what happened with demographics there. I don't know, but we just like have a lot of patients all the time, where it used to kind of fall off a little bit in the summer and allow you to take like a summer vacation or something. Don't have that anymore. All right. So any questions on any of that? No? You know what to expect in the next class. All right, so turn in your skills book, your white skills book, to page 57 for me. Okay. So this is our skills page. And this, we've seen this before. This is not new to us. We've done 2 other range of motions already. We did range of motion of the shoulder. And if you remember, range of motion of the shoulder asks us to do flexion, extension, and abduction, adduction. So flexion, extension was up, down. Adduction, adduction was side to side. Okay. Remember, rotation is around. Now, I do want to talk about rotation on ball joints, like the shoulder and the hip. Even though we're not being asked to do it, I do want to discuss it really quickly. Rotation on ball joints is not what you think it is. When I ask you to rotate your shoulder, you're probably going to give me a big old pitcher wind up, right? Because this is what we think of with rotation, but that's actually not how rotation is effectively done. So everybody stand up for 1 second. Try to give yourself a little space so you don't knock anybody out. And do a big pitcher wind up, right? And feel the muscles that works. Kind of get an idea of what muscles that works. Okay, now hold your arm out, palm up, and rotate that arm so it's palm up backwards. Now do that a couple times and feel. Do you guys feel that that's a totally different set of muscles and they're more in the joint? Do you guys see that? This is working more of the outer. This is working more of the inner. Do you guys see that? Okay, go ahead and have a seat. So rotation of ball joints is different than what you expect. It's going to be more like rolling cookie dough when we do it on a patient. So if I'm going to rotate the arm, I'm going to roll it along the bed. So if I'm going to rotate the hip, I would roll it, 1 hand above the knee, 1 hand below the knee, and roll it in and out. Remember, we only go to the point of resistance or if we notice pain. Okay. Now, generally speaking, rotation of the hip is not going to be done by CNAs because, unfortunately, rotation of the hip can result in some pretty bad injuries if done improperly. So in general, physical therapists are going to be doing rotation exercises on the hip, but that doesn't mean that you can't. It just means we have to be careful. Good? Does that make sense? So how would we know if we're doing rotation on a specific individual? The care plan. So this care plan tells us to provide the following range of motion exercise to the resident's right hip, knee, and ankle. Flexion, extension. That's it. That's all we're going to do. And if you remember, flexion extension was up, down, right? Provide 3 repetitions of the exercise. That's because it's the test. 3 repetitions in a clinical setting isn't going to get you a whole lot. So it would probably be 3 sets of 10 or something like that. That's something that gives us a little more effectiveness. And then it says the resident is not able to help with the exercise. That means we're doing it. We're going to do the range of motion. Remember, active range of motion is when we tell the patient what to do, they do it, and we just make sure it's being done correctly. That's not this. This we are going to do. So good? Questions so far? All right, so if we're going to do range of motion of the hip, knee, and ankle, we need to understand that the hip and the knee are done at the same time. So when you have a patient laying down in bed and we lift their leg and bend the knee toward the chest, that bends this hip and it bends this knee. Now, why wouldn't we do them separate? Well, if you try to just bend the hip, just the hip, this becomes a straight leg raise. Okay, keeps the knee straight, becomes a straight leg raise. This puts an incredible amount of pressure on your lower back and specifically your sciatic nerve. And patients with any sort of a sciatica will not be able to tolerate a straight leg raise. You have to think about the nerves. Okay. So I can't get to my book, but think about the nerve. So you have a nerve that runs from your lower back straight down the back of your leg to your heel. Okay, one long nerve. Now, if I had a rubber band, I could show you this, right? So if we have a nerve and it's normally in this position, when you do a straight leg raise and you move that leg up, it actually makes that nerve stretch because we're elongating it. If you've got sciatica, those nerves don't like to stretch. So patients get really, really frustrated with that. So in general, we don't do straight leg raises. Now, if we elevate the knee to the chest like this doesn't stretch that nerve. It's actually, it kind of compresses it like an accordion. So it's able to be tolerated a little bit better. Does that make sense? So this exercise, flexion extension of the hip and knee, gets both of those joints at the same time. Now we always want to support at the joints. Remember, 2 points of support, and we support under the leg, not above it. So we're going to lift the leg between under the knee and around the ankle. We're going to bend the knee to the chest as far as we can. May not go all the way to the chest. And then come all the way back down to start. How many times we're going to do that? 3. And we're watching for any sort of pain or discomfort or anything, and we can ask them. And then after we're done with the 3 hip knee exercises, because that's a 2 for 1, then we're going to take this foot and go up and down. Remember, flexion extension is up and down. But I don't want to do this with the patient's leg on the bed, because if I flex the foot forward and back to the head, that heel is doing this on the sheet, scraping that sheet. Now, if my patient has thin skin, what could happen? Sure, absolutely. So we want to get that leg off the bed just a little bit, just so the heel isn't going to scrape on those sheets. So we're going to elevate that heel with a hand below, and then we're going to push the foot forward like they're stepping on a gas pedal, and then back to their head so they get a stretch. For how many times?
3.
That's it. There's your skill. Put an opening in front of it and put a closing behind it. Not a hard one at all. I'm really bummed my little thing isn't working here. Okay, so let me get somebody over here on the bed, and I'll show you this one.
I'll go. Let me empty out all my pockets because I don't need it emptying out on the bed.
Let's see here.
I don't think everybody wants a cigarette one. Up on the bed.
Yes, please.
Who's on her own?
There we go. On is fine. Check that out. I got picture. Pretty cool. Okay. So for this skill, I'm going to assume that I've already, that I've already done skills before, and the evaluator has told me I can simulate hand washing for this skill. Hi, Ms. Jones. My name is Patty. I'm your CNA today. How are you? I am fantastic. I need to do some exercises on your right hip, knee, and ankle. Is that okay? Okay, I'm going to close the curtain, go wash my hands, and I'll be right back. I have clean hands. Bless you. Now, what if I wasn't sure which one I was supposed to do, right or left? Yeah, so you can stop in the middle of the skill and go back and read that care plan if you need to, okay? All right, Ms. Jones, I'm going to do all the work. All you have to do is let me know if there's any pain or discomfort as we do this, okay? Now, remember, I can raise the bed up to a comfortable working height if I need to. That's no problem. But what do I need to remember to do at the end? Lower it all the way down. I'm not going to raise it. Okay, I'm going to bring your knee up to your chest and back down to the bed like you're climbing stairs, and I'll do all the work, okay? So under the knee and hold the heel. We're going to go up and all the way back to the bed. 1, feel okay? Up, all the way back down. 2, still good? Up, all the way back down. 3, good? Any pain or discomfort?
No.
Okay, so now we're going to work on the ankle. I'm going to lift your foot up just a little bit off the bed and bend your foot forward like you're stepping on a gas pedal. Okay, vroom, vroom. So we're going to go forward and back. Feel that stretch? Does it hurt? Forward and back. Still good? One more, forward and back. Good? Any pain?
No.
All right. So let me go ahead and open your curtain. Are you comfortable? Is there anything else I can get for you while I'm here? Like a magazine? Okay, call light is right here. Let me go ahead and put this in your hand. There we go. And if you need anything at all, just press that red button and I'll come back, okay? All right, my environment's clean. I have clean hands. My skill is done. Thank you.
Can I ask you a question? When you take the test,
Sure.
they're just gonna hand you the 3 skills, which would be the care plan?
So this is what they're going to hand you. Mine has pretty decorations. Theirs is just words. They're not going to give you your timing is not printed on the card either. What they're going to give you are these words right here. Okay, the title and then the specifics.
And
This
you'll be
is
able to just keep that in your hair, or you set it aside?
right. They're also going to read it to you.
Oh, okay.
So if it's your testing day, they would take you into the room with your partner, whoever you've been partnered up with. They're going to show you around, and then they're going to pick one of you to go first. And let's just say it's you. So this is your skill set. The evaluators are going to read this paper to you because they can't trust that you know how to read effectively. And then they're going to hand it to you, and that is now yours throughout the entire test. You're going to put that in a visible place, and there'll be, you know, a table. You can put it on the overbed table. You can, you know, put it on the supply shop, put it somewhere you can see, but that is yours for the entire test. You are free to look at that anytime you want. Okay. Good question. Any others? Any other questions? All right, so 1 out of the 3 skills that we needed to learn today is done. The next one's not going to be quite so quick. Give me 1 second here. In your white skills book, before I move away here. Yes, absolutely. Hi.
Aesthetics, you know, you don't do much with it, but you do clean it.
You will have to be cleaned. You will have to be trained on cleaning the prosthetic for that specific individual, because prosthetics are highly customized. There are no 2 that are exactly the same. And it depends on, I mean, they'll use different materials, they'll use different compositions, they'll use different attachment protocols, they'll use, I mean, just they're completely different.
I think I mean more like the
Right. And again, everything is going to be different.
Okay.
So you're going to have to be trained on that particular individual. And a lot of it depends. Are we talking about somebody who has had an amputation in the last 2 weeks, or somebody that had an amputation 20 years ago? those two are going to be, cared for completely differently, completely. We also have to look at, is this a stump that has been well cared for? The skin is intact, everything is good. It's, just like any other body part, soap and water. Or is this maybe has some bone fragments that are, wearing on the skin, causing hot spots, or maybe we have a rash from heat, because when we put on a prosthetic, you're putting on usually a sock or some other sort of a enclosure, and then the prosthetic goes over that. That holds in body heat, warm, dark, moist. So you can get infections, especially yeast type infections in that type of environment. So are we battling one of those? There's a lot of possibilities there. So it's not a one size fits all situation.
So each like agency would kind of.
So let me go over that with you real quick, because this is a very common fear of CNAs. When you're done with class and we release you out into the wild, which is what we're doing, you do not have all the information you're going to need to operate wherever you end up working. You'll have a foundation to build on, but you're not going to know everything. You're not going to be able to be plucked, out of class and deposited into a long-term care setting and go. You have to go through an orientation period. Everywhere you work, you'll go through orientation. Now, that orientation is going to differ depending on where you end up. So if you end up in mental health, orientation, way different, totally different than if you were orienting in a hospital setting. Now, in a hospital setting, second floor orientation, way different than neuro ICU. So even within a facility, orientation is going to vary, because you're going to have different things to do with that patient population. If you're working in telemetry with cardiac patients, they're probably going to want you to learn a little bit about the blips you see on the screen, because you're in and out of the room a million times. So if you can recognize that these big old loops probably aren't a good idea, and you can let somebody know, hey, big loops on the screen, go, run. That helps the patient get prompt treatment. But learning how to read telemetry will help you not a bit if you're working in mother-baby unit. There, you would want to learn how to read the contraction monitor, so we know if we're getting closer. So everywhere you go, you're going to have a little bit different training. Now, let's say you want to work in home care. You want to work one-on-one with a patient. Well, we don't just give you, okay, here's Henry, go. You have to learn a little bit about Henry and what he's going to require. Now, if it's a good agency, they'll actually meet you there and introduce you to Henry and give you a little bit of training on what Henry likes and what he doesn't like and how we're going to do this and that. But if Henry's at home, chances are Henry can give you a lot of that information himself, because remember, we're there to help. And it's not help if we're not helping the way they want to be helped, right? So sometimes they may not meet you out there, although that is preferred, right? It's really weird to walk into a stranger's house and go, okay, I'm here to take over. That's a little odd. It's better to have an introduction. But if you don't get one, because let's face it, we're short-staffed. If you don't get one, you'll still have a care plan that tells you what you're authorized to do. Basically, what are they paying for? That's really kind of what that is in home care. And you're going to find out from the patient or the family how they would like certain things done, using what you learned here as a foundation. So anytime a patient's uncovered or undressed, what do we need? Does that vary at all depending on, did I say anything about, well, in a hospital or in a nursing home, or if the patient's uncovered or undressed, what do they need? Yeah, privacy, some sort. I don't care if it's a towel, a blanket, I don't care. But cover their dangly bits, right? So what I've taught you here is a good foundation that you're going to use while you're learning what to do with those patients in your environment. But they're all going to be different, every one. And even worse, way worse than that, once you get settled in your facility, all the patients are going to be different from each other. So there is no one size fits all. This would be so much easier if it were a factory and I said you put this here every time, this here every time, this here every people don't work like that at all. Not even close. So we need to have that understanding going into this. So wherever you go to work, you're going to have an orientation period. Be open to learning the skills they need from you in that setting. But you're going to use what you've learned here as a way of making that education easier. But that also means that when you want to go to a different setting, you might require a different skill set. So let's say you've worked in assisted living for 6 years now, you're ready for something new. It's not much of a challenge anymore. So you decide to go to work in a walk-in clinic, better hours, maybe better pay, I don't know. So you go into the walk-in clinic and you think, I got 6 years experience as a CNA, I got this down, no problem. And they're going to laugh at you because you have 0 years experience in a walk-in clinic. And here, we don't do what you did there. There is absolutely no bed making in a walk-in clinic. None. 0. We don't bathe people in a walk-in clinic, although some of them probably need it. Right? That's not what we're there for. But man, you are going to get really, really good at vital signs. Really good. You're going to get really good at talking to patients to find out why they're here. Now, long-term care, we want them to talk. We want them to tell us their stories. We want to connect with them on a personal level. We do not want that in a walk-in clinic. We want short and sweet. Why are you here today? I don't want to be trapped in this room for 30 minutes because I've got 30 patients. So you learn different skills, different ways of communicating with patients. Everything changes. Everything changes, which can get really frustrating for you. It's like, why did I go to school for 4 weeks to learn how to be a CNA when you're telling me that everything out there, I'm going to keep learning. It's all going to be different. Remember that this is a foundation. You can't learn that unless you have this. Does that make sense? Got it? It can get really, really frustrating. I know. I know. So I told you that I'm plugged into a lot of Facebook groups online, CNA groups online. And there was one this weekend that really kind of cracked me up. She said she had 10 years experience in a nursing home. And she was moving to a mother baby unit in the hospital. And, you know, what do I expect? And that's a very common question. Nobody can answer that because it's going to vary day to day. You know, but yeah, but, you know, I understand the anxiety there. I get it. But she says, I'm trying to remember how she put it, but it just kind of made me laugh because she doesn't really truly understand that CNA work varies from place to place. And even though she's asking, what do I expect? So she knows it's going to be different, but she's like, well, I've got 10 years experience. I don't understand why they expect me to go through orientation. It's different. Yeah, it's a different type of care. So when you're in orientation, make sure you're asking questions, make sure that you're open to instruction, find the policy and procedure book. And this one just, I usually spend some time talking about this, but you've got a policy and procedure book everywhere you go. How many of you guys work right now? Somewhere, anywhere. You work anywhere? Do you know where your policy and procedure manual is at your current job? Probably not. Probably not. When was the last time you opened it? Never did. We don't pay any attention to that at all. None. It's a book that sits on a shelf that some manager writes, and I don't care. You should care. You should care a lot. Because if the facility gets sued, let me back that up. When the facility gets sued, because Morgan & Morgan has to pay their light bill. Okay. They will talk somebody into suing somebody else. I guarantee it. Just watch TV and you can see their advertisements. So when your facility gets sued, you are going to be deposed. You will. So you're going to be in a very uncomfortable position in an uncomfortable room, and they're going to be asking you all kinds of questions. And one of the questions they're going to ask is, when you performed this skill, how did you do it? And they've got a copy of that policy procedure right in front of them. And if you did not perform care according to the way that book told you to, that facility is liable. You are liable. So that policy procedure book is every bit as important as our care plan. Policy procedures tell us broad strokes how to do stuff. Care plan tells us how to adapt that to our patient. So if you don't know where the policy and procedure book is, you're in trouble. So during orientation, you honestly should spend a couple of hours sitting at a desk, looking up the policies and procedures for tasks that you normally do, things you know. Bed baths, gonna do them. What do they want here? Because I can tell you, in a hospital setting, bed baths are not basin soap and water. They are packets of wipes that are in a warmer. And there's 2 different colors. And you got to know which color is for which use.
Just for my orientation across the street, I had to do all these courses online. And most of them had to do with policies and procedures.
Yep, absolutely.
So, yeah.
It's that important. Oh, good. Awesome. Awesome. So your policies and procedures tell you broad strokes, how it's going to be done here. Care plan modifies that for this patient. Does that make sense? Super important. So you need to spend some time going through that book. Super, super important. One of the places that I worked, I loved the way they did it. They had a scavenger hunt in their policy and procedure manual. And you had a whole bunch of symbols that you had to find and write down what page you found them on. And it, it got you to go through the policy procedure book to see, and basically the ones that they really needed you to focus on were the symbols that they were looking for you to find. So I thought that was a really innovative way of getting people to take it, to at least take that step. Good? Makes sense? Super important. Very important. All right. Let me just check my chats here. Good morning, guys. Okay. All right. So this should look vaguely familiar to you. We talked about this last week, last Wednesday on Care. We talked about the normally function urinary system. You have 2 kidneys. They filter blood 24 hours a day, all the time, never take a day off. And they remove waste products from the blood and produce urine. Those urine drops drip down tubes called ureters into a bladder. That bladder is going to hold the urine in there. A little valve at the bottom keeps the urine inside the bladder until it gets full. You find a bathroom. You go to the bathroom, the valve opens, urine comes out, valve closes, you're good for another couple hours. You guys remember this? Okay, this is important because we're now going to talk about how catheters impact this system. But I needed to refresh you on how the system actually works normally. So now, so this is that same system with a catheter. So when a catheter is introduced through the urethra, once we get the catheter in place, we blow up this balloon with water, and that holds that catheter inside the bladder. It acts kind of like a little doorstop, just keeps it from sliding back out, because without that balloon, it would literally just slide right out. So the catheter is inserted, the balloon is blown up with water, and now it just sits there. Now, as the kidneys filter blood, produce urine, the urine drops go down the ureters into the bladder, but they don't stick around because there's holes in that catheter. So that means the urine goes through the holes into the catheter, through the tubing, and is collected in a bag. Good? This is a closed system. The only opening is here inside the patient and here where we empty the bag. Now, there is another opening here we'll talk about in just a little bit, but this is a closed system. And as long as we treat it right, we don't end up with bacteria in the system. But it's important to understand how that works. So here's a close-up of what happens when we put a catheter in. When we advance the catheter, we go through that little valve and we get into the bladder. We know we're in the bladder because we end up with urine in the tube, in the catheter, we see it. Once we're in the bladder, we're going to inflate that balloon, which kind of keeps it there. But all this catheter does is hold that valve open. That's it. That's its only mission in life, is to hold that valve open, and then the urine goes through the tube and out. Good? Now, why do we even use catheters? Well, we don't use them for convenience. If you've got an incontinent patient, like they're leaking all the time because the valve is broken, the urine is coming out. It doesn't need your help. It's coming out just fine on its own. So we're not going to do anything about that. We're just going to clean the patient every 2 hours around the clock. We only use catheters when we absolutely have to. Have to, not want to. Not it would be convenient to. Have to. Now, the reason that that's important is because of infection control. Okay, give me just a minute. I'm going to show you this. Okay. Now, there's a couple of different types of catheters, and that's what I want to talk about for just a minute here. So this one is called an indwelling catheter because we put it in and it stays in. It dwells there. It's kind of a longer term solution. So indwelling has this little bubble on it to keep it in place. But we don't always need a catheter to stay in for a period of time. Sometimes we just want to put a catheter in to get a urine sample and take it right back out, or to drain the bladder or something like that. That's what this is. This one does not have a bubble at the top. This is called a Red Robinson or a straight cath. This is put in specifically to drain the bladder, but it's not going to stay. Now this one is an indwelling catheter or a Foley catheter. That's the terms. So when the nurse puts this in, CNAs do not put in catheters. You don't take them out either. You can be trained for those tasks. That's delegation, but you would have to be trained. It's not a routine CNA task. But if, as the nurse, if I decide that I'm going to put this catheter in my patient, they have different sizes of catheters. This is a 16 French, which is pretty standard. We do have catheters that are a little smaller and some that are a little bigger, but this is like pretty standard. This is going to be lubricated and inserted through the urethra. The tube is already there. We're not drilling anything new. Tube is already there, but it's going to be a snug fit because I don't want urine leaking around the tube. Remember, we're holding that valve open. So we don't want a lot of urine leaking around the tube. So when we put this in, it's going to be a very snug fit. So it's going to be a little uncomfortable for the patient. Shouldn't be painful, but it probably isn't going to feel like a picnic. Okay. So this gets inserted into the bladder. When we start to see urine, we know we're in the bladder. So then we take a syringe filled with water and we inflate this little bubble. And that is what's going to keep that catheter in place. Now, when the catheter is ready to come out, time to remove the catheter, we're going to take a syringe and pull the water out. And then it slides right out. Now, unfortunately, what happens is sometimes people that don't know what they're doing will pull a catheter out without deflating that balloon. No, nurse. Yep. But I find it's helpful if you understand what's happening and that you know what it looks like inside the body. So with this in place, with the balloon inflated, you can put a fair amount of pressure on here. I mean, you can kind of yank on this a little bit and it's not going to go anywhere because it's sitting on top of that, that opening to the urethra. It's kind of small. So this is way bigger than this, right? So it can handle a fair amount of tugging. You don't want to tug too hard though. We're going to talk about that in a few minutes. But you don't feel this. You do not feel. It's inside a bladder, a hollow organ. You don't feel this. Imagine how much pee you have inside your bladder right now. Way more than this. Way, way more than this. This is only 3 cc's. Like that much. Right? So you don't feel this. What you feel is this. This is, I mean, it's not hard. It's very soft, but it is stiff. Now, inside your bladder, at the top of your bladder here, you have some nerve cells, sense cells. And the only thing that those nerve cells have ever felt ever in its entire life is pain from a UTI or pressure from pee. Bladder nerve cells are a little stupid. They don't have a whole lot of big vocabulary. They only have 2 words: pain, pressure. That's it. So when this goes in, we blow up the balloon. This, because we're keeping the bladder small, there's nothing in it. No urine is stretching it out. So bladder stays kind of small. So this hits the top of the bladder. And the bladder goes, that's not really pain. It's pressure. Yeah. So the only thing that I've ever felt for pressure is I have to go to the bathroom. So what do you think this makes a patient feel like? Yeah, pee. Give me to a bathroom, pee. So when a catheter goes in, it's not uncommon for patients to feel like they have to pee. That's normal. No problem. Now, a lot of times caregivers will say, oh, just go, just go. There's no going. They're not trying to open a valve. There's not just because then they'll concentrate on like trying to go, and that's not going to relieve this, right? This is because the catheter tip is hitting the top of a bladder. And the bladder's not happy with that. This sensation goes away about 8 to 12 hours. So if you can tell your patient to like distract, take a nap, read a book, watch TV, distract, the body gets used to that being there. That sensation tends to go away. Now that's different than if the patient has pain. If the patient says, ow, 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 it hurts, go get the nurse right away. That's different. I have to pee. That's just the top of the catheter. That will fade. Pain does not. Anybody ever have a Charlie horse? What does that feel like? On a scale of 1 to 10. Yeah, I was thinking 12, but yeah, 20 would work. Yeah. So what happens in a very small percentage of the population, very small, but it does happen, is that when we put this catheter in and we blow up that balloon, the bladder says, oh my gosh, you don't belong here. You are an intruder. And it spasms to try to force that out. This is a muscle spasm of the bladder. So think Charlie horse of the bladder. This is pain. This is pain like you have never experienced pain. So if the patient says, ow, 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 it hurts, that is not a, oh, distract yourself, it'll go away. That is, go get the nurse now. Now, as a nurse, I've got some medication I can give this patient that'll put their bladder to sleep. That's a good thing if we're having bladder spasms. The problem is that all medications have side effects. In some patients, again, very, very, very small percentage, but in some patients, when we put that bladder to sleep, we are unable to wake it up again ever. Ever. So there's a risk that goes along with that. It's not just, well, I'll just give you something and it'll make you feel better. There's some risks here that we have to evaluate. So my very first question is, do we even need this catheter to begin with? Do we have any other way this patient can empty their bladder? Any, I'll take any suggestions because I want to try to get rid of this situation if possible. If I can't, then we're going to look at, some medication options and things like that. But it's not, we rely on you to let us know what the patient is reporting. Does that make sense? Okay. So you've got to work with your nurses. Remember, it should never, remember me saying on the first day, it should never be you versus the nurse, because who loses? The patient. And in this case, the patient would really lose.
For example, I guess in any workplace, there is an issue with this symptom or any other symptom that you're working as a CNA.
Yep.
And you report them out. You always will have that. But this is now a medical field that we're looking at. What if some reason you're in the nerves?
Right.
And you still see nothing is being done. What can you do then?
Okay. There's 3 answers to that question, to be brutally honest with you. Number 1, things may be being done, you just don't know about it, because they're not going to report back to you. There's no need, right? They're not going to keep you updated on their tasks because you are their assistant, they're not yours. So we kind of have to keep the roles defined there. So there may be things going on you just aren't aware of. But on the other hand, there may be lazy nurses. I mean, there are. I know there are. So if you report something to the nurse and it doesn't appear that anything is being done and you are concerned about the well-being of the patient, you can follow up with the nurse. Hey, I told you they're saying pain, they're still having pain. Are we doing something about this? And they may say, yeah, it's being handled. Okay. Maybe they ordered the medication. It hasn't come up from the pharmacy. Maybe they have a call in for the doctor to get orders. Maybe, we're going to be irrigating the bladder with a solution to help remove some of that impulse. I don't know what's happening. We won't know what's happening, but you can follow up with the nurse and just say, hey, is this being handled? But sometimes nurses don't like being second guessed. So that can cause a little bit of animosity. But if you know that the patient is not getting the care that they need, and you followed up with the nurse and it doesn't seem like we're getting anywhere, you would go up your chain of command. So you need to look at who is that nurse's supervisor. So probably the charge nurse, could be the assistant director of nursing, but you're going to go up your chain of command. Absolutely. And you wouldn't go straight to the hospital administrator and say, hey, you got a bad nurse over here. You go up your chain of command, and that gives them an opportunity to kind of somebody above the nurse that can double check, that can get all the information that we don't have.
Especially like if we're being nursing homes and you have same people every single day, you sit with them. Like you said, we will have conversations, and they keep saying it, and they're telling me, you have to, especially this in the field, is very important. And it's just like we're CNAs, but at the same time, we also have to keep an eye out as well, because then.
Right.
Like we have to line them up.
Right. And like I said, I wish.
They complain about something and nothing's being done. You don't want to, but especially then I would be at risk. I'd be at risk for not saying nothing. I see nothing being done, and something happens to the patient. Yeah, exactly. Yeah. And they're like, well, she was there. It'll come back.
Remember that the nurse is ultimately responsible for the patients, not the CNAs. And it's that way for a reason. So the nurse can never say, well, you didn't tell me. That's your responsibility. You're supposed to be in there doing a head to toe assessment on those patients every day, every shift. So that is not. Well, not necessarily. We're going to talk about documentation in a few minutes, but CNAs do not document with words in most settings. You're not going to have the opportunity to write down somewhere, I told so-and-so this. That's not part of the medical record. And because medical records are legal documents that can be called into court, they usually don't want you writing with words, right? So CNAs generally document numbers, percentages, or output, or things like that. Vital signs. CNAs document numbers, not words. Now, in some settings, you will. There are some settings that will let you document in words, but they're getting further and further. Yeah. So no, there's nowhere for you to document, I told Susie this. So, and if Susie says, well, she never reported it to me, it doesn't matter. Susie can say anything Susie wants to say. The legal framework is that the nurse holds liability. That's it. That's not an employer framework. That's not the nurse's integrity. That is a legal framework. The licensed individuals hold liability. That's the nurse. I won't tell you you won't lose your job. Yeah, I can't promise that, because you have to think about simple mechanics here, okay? How long are you guys in this class? 4 weeks. So if I fire you within 4 weeks, I can have a replacement just like you. Doesn't take much, right? So if I've got a discrepancy between you and the nurse, if I fire the nurse, it takes 3-4 years to retrain a new replacement. Now, certainly I can hire somebody that's currently, licensed. Yes, I know. But I'm talking about just in terms of training, right? There's a whole lot more CNAs. That's right. Absolutely. You are, because you are the easiest to replace. Now, they are going to skew on the side of the nurses, right or wrong. I can't, I don't know, but they are going to skew to the nurses because it's harder to replace a nurse. But if they lose 5 or 6 CNAs at the expense of this nurse, remember, it costs money to hire every single one of you. So yeah, and train and everything. So at some point they're going to look at the nurse and go, you aren't working out. Let's get a different nurse in here and see if we can connect a little better. Does that make sense? So I won't tell you that you're not going to get fired. But as far as that's different from liability. Liability is legal.
The doctor did this, if we can, it won't work, like you said, we have to run numbers, blood pressure, things like that, how many ounces, food and water. And we tell them it happens if they didn't correct something or something is wrong. Like you said, the nurse is ultimately responsible, but then it comes down the chain, everyone underneath her goes. And if it's something that wasn't our fault, and it's something that was on the nurse's side too. And at the same time, this is a patient. We're helping take care of. You don't want to see nothing happen to them, any type of harm.
Right. And I absolutely agree with you 100%. And I wish I could tell you that, you're not ever going to be at risk. You are, but hold on one second, guys. I think they're trying to tell me something here. Okay. But that doesn't mean that how do I put this? In any workplace, it doesn't matter whether it's medical or manufacturing or food service or anything, you're going to have personality conflicts. You are. Right? When you're working with other people, there will be personality conflicts. So I don't want you to invent one before you get there. Okay. There will be personality conflicts, but you're going to want to try to work with the situation as much as possible. Is it possible that a situation could come up, you report it, the nurse doesn't do anything, the family gets involved and everybody gets fired? Yeah, that's a possibility. And you can say all day long, well, I told the nurse, but that doesn't make any difference because that facility is trying to reduce their liability by getting rid of the people that were involved in the situation. And I'll give you a great example. I told you about the young woman who was comatose and got pregnant, right? The male nurse, they did a DNA test. It was the male nurse that impressed. She is incapable of giving consent. This was definitely a rape situation. But several other staff members lost their jobs over this as well. Think about all the CNAs that bathed that patient. Yeah. She was pregnant. So, and somebody may have said, hey, she's getting a little round, or something's going on here. It's possible that somebody might have reported it. It's possible. I wasn't there. I don't know. I have no idea. But at the end of the day, that facility is taking no chances. They're getting rid of everybody involved in that situation because it doesn't look good. So is it possible you could get caught up in something like that? Sure, absolutely. It's possible. But that shouldn't keep you from working in healthcare on a possible something somewhere down the road. Okay. Yeah, yeah, yeah. You're going to report all your observations to the nurse. If you don't feel that it's being taken seriously, you can ask the nurse for clarification. If you still don't think it's being taken seriously, you go up your chain of command, just like in the military. So is it possible that, you know, some high ranking military person could get caught doing something and everybody down the chain get reprimanded? Sure. Absolutely. It's every single industry. Yep. The lower you are, the more expendable you are. Yeah. I mean, and that's just, you know, economics. Yeah, it's life. Yep. And, you know, don't think that the people higher up the food chain are not at risk either, because almost every one of those administrators in a facility where something goes wrong loses their job. Same thing with the DONs. You know, you're dealing with people. Okay. There is no such thing as safe. What I need you to know what to do is, if something should happen, like the patient says, it hurts, what do you need to do? Don't worry about whether other people are doing their jobs so much. Do yours. But if you notice that it's having an effect on the patient, you can report up, just because we're concerned about the patient. But you got to be careful on how you frame that. If you come to me, if I'm the assistant DON, and you come to me and you say, you know, I told Tina, the nurse, that this patient was having this problem and she hasn't done anything, that to me is a personality issue. That has, you did not tell me anything about the patient in that statement. Now, if you come up to me and you say, I'm concerned about Mrs. McGillicuddy because she's having these symptoms and it doesn't seem that they're being addressed. Now that's something I can work on. Do you understand the difference there? It's how you present it. Are you patient focused or are you staff tattling focused? So you got to think of how you're going to word that as well. Okay, so we understand that there's two different types of catheters here. We have an indwelling with a bubble that holds it in place. You've got a straight cath without a bubble that's used temporarily. Indwelling catheters like this can be left in place up to 30 days. So if we have a patient that needs a long-term catheter, this is going to have to be changed out every 30 days. Because over time, that balloon, when it's stretched out like this with fluid in it, and the acid in the urine is going to affect that material. So over time, it's actually going to degrade that material. So every 30 days is our benchmark right now. But here's our problem. When we have a catheter in place, if we allow bacteria to get into that catheter system, remember it's a closed system, right? One end is in the bladder, the other is a bag. If we somehow allow bacteria inside that system, there are no white blood cells anywhere around. Remember I said that we don't need little boy bacteria, little girl bacteria. All we need is the right conditions and they zip themselves in half and make a clone. You guys remember that? One bacteria in this system will become 2. 2 becomes 4. 4 becomes 8, and so on. Well, as these bacteria multiply inside the system, they climb because they're looking for fresh food. There's too much competition down below, so they start to climb. And they're protected from our body's defenses because they're in a secret tunnel. You do not have any white blood cells inside that catheter, which allows those bacteria to multiply. So by the time they get up into the bladder where they're climbing out of the holes, it's not 1 or 2 bacteria, it's 1 or 2 trillion bacteria. And it's a infection that happens that fast. It's quick. And it's because we weren't able to get control of the problem. There were no symptoms. Your body had no idea that these bacteria were even there until they climb out inside the bladder. And what do we know about the bladder and bacteria?
Favorite spot.
Yeah, favorite spot in the world. So now we've got an overgrowth of bacteria in the bladder, and then they start to climb these nice little exit ports. And where do these lead? Yeah, and that is a problem. This is why catheters are not used unless we absolutely positively have to use them. If the pee is not coming out normally, so if the patient has a big tumor here that is pressing that urethra and the pee can't come out normally, that is an appropriate catheter situation. If we're having surgery and we're putting you to sleep, we put everything to sleep, including that valve. We don't want you peeing on our sterile field. So we put in a catheter during surgery. If you get an epidural for childbirth, you can't get up and walk to the bathroom. In fact, you aren't even aware that you have anything below the waist. So we need a catheter in place.
When I had my youngest, they didn't put a catheter in when I got the epidural.
That's very unusual. Very
Yeah, because
unusual.
Right after I remember getting up, because with my middle daughter, I had gotten up, went to the bathroom afterwards, and so I was like, hey, look, third kid, here we go again. Have the epidural, get up, go to the bathroom, landed on my butt.
Yeah. Yeah, because the whole purpose of an epidural is to block all sensation below that point, around the waist. So there's no way for you to walk because there's no, you're not even, your brain doesn't even know those muscles exist. So it can't tell them what to do. So anytime we put an epidural in, we put a catheter in too. Now, there are situations where maybe we won't use a catheter, and in that case, the patient becomes incontinent. And this is if we have a very short window. Like if you come to the hospital, you've got contractions 20 seconds apart, you're 90% dilated, you're going to give birth. Yeah, you're going to give birth right away. There may not have been a whole lot of time to work with there. Remember, every situation is different. You change one parameter and it changes the scenario, right? We talked about that this morning. So in that case, there may not have been time, but generally speaking, if we put an epidural and we erase you from the waist down, we have to have a way of capturing the urine. Because anybody that is pushing a baby out is pushing everything out. It's not selective pushing. If you've got something inside you, it's coming out during childbirth.
I'm like one of those worst patients. You don't knock me out in the first 5 and you have to put me under. It had kind of come in because you get someone like me and then they get scared.
Yeah.
I don't fall asleep right away with the anesthesiologist, the epidural. So I'm always in a difficult.
Yeah.
And then that's my thing.
Yeah. So in that situation, a catheter would be indicated. But if we just have plain old incontinence and the urine's coming out on its own, we don't need a catheter. Urine's coming out, right? So it's important to understand that catheters, because of this risk, are not used for convenience. They're used for necessity. If the urine can't come out on its own, or it's coming out in an inopportune time or place, that could be a problem for us. And then a catheter would be indicated. Make sense? Okay. So we talked about this. This is a closed system. This part is inside the patient with a balloon. This catheter tubing is going to connect to a bag of some sort. Now, there's different types of bags, different sizes of bags. There's all different possibilities here. But there's only a few places that bacteria can get in here. Now, bacteria can get into the system when we put the catheter in, if we don't clean the area really well And now we got bacteria living in the tube, and that's a problem because they're going to multiply. So putting this in with sterile technique becomes a super important task. We can get bacteria in the system here, which we're going to talk about in just a few minutes. And we can get bacteria in the system when we drain it, when we empty the bag. And that's what we're going to focus on here. CNAs should not disconnect this unless you've been trained to. Remember I said that these catheters can last up to 30 days? Well, the bags are usually changed once a week. So if the bags are changed once a week, but the catheter can stay in for 30 days, that means that you're going to have to disconnect this to change the bag. But remember, if we disconnect it, that allows bacteria into the system. So you've got to be trained on how to do this to try to minimize any sort of bacterial influence. Let's talk about catheter safety. When we have a catheter, the bag is going to be positioned below the hips at all times. So this is a catheter attached to a bag. This is the kind of bag that we use in most clinical settings. It's called a bedside drainage bag. And it's large. It's going to hold quite a bit of urine. And this is good if the patient's laying in bed. Remember, this part is inside a patient. Okay, this part is inside a patient. So this bag is good if the patient is laying in bed, not really mobile. But if they're going out to Walmart later today, they don't want to carry a suitcase of urine along with them. So they want something that's a little more discreet, and that's where a leg bag comes in. It's a smaller bag, and it's going to Velcro to the inside of the thigh or the calf. And it still is a bag. It's still below the hips. Urine is still going to collect in the bag. Because it's smaller, it's going to have to be changed out or emptied a couple more times because it's not going to hold as much. Good? Make sense? So changing the bag can be a CNA task as long as you're trained on it. Okay. So this is a bedside drainage bag. Now, this is what they're going to use on the test. Bedside drainage bag. We're going to learn this skill in just a few minutes, emptying this bag. But the way that we empty it is through this port right here. This port cannot touch anything. Nothing. We're going to remove it from its house. It's a T valve, so you would slide it to the side to open it. Now it's open. And then when you're done emptying it, you're going to slide it to the side to close it. And then you're going to very, very quickly put it right back into its house. This port cannot touch anything because that's what allows bacteria into the bag. The number one contaminant is this port. And that's what we use as CNAs. Okay. So bags should always be kept lower than the patient's hips. Tubes should be coiled on the bed, not near the floor. The bag needs to be hung from a non-moving part of the bed. We're going to look for a catheter before we move a patient. And we're going to report patients that tug on catheters. Okay. So pull it out of its little house. Nope, right here. So you're going to hold here, pull down, and bend. Yep. You're going to close it, close the valve, push it the other way, yep. And then not at the top, but you can put your finger on the, yep. Well, you're not going to touch it unless you have clean gloves, but you're never going to touch the top of the port, ever. Not with anything. Not with anything. Not with anything. Right.
Heart patient and a dementia patient. Really? Yes. The heart patient doesn't want to go in the first place.
Yep. So this is very, very important. We don't want to lift the bag above the level of the hips, because that means that the urine is going to go right back into the patient, and that urine is going to pull any bacteria that might be in the tube along with it. So remember that pathogens don't fly or crawl well on, they have to have liquid to move. Well, if that urine flows into the patient, it's a tidal wave of bacteria going right into the patient's bladder. So never move a bag above the level of the hips. And I've seen this. People walking down the hallway of a hospital with an IV pole, they'll have the urine bag hanging on the IV pole. And I don't know about you, but that's recycled urine is pretty high on my gross meter. This should be a one-way trip. I don't want recycled urine back in. So never elevate the bag above the hips. You also want to make sure that the tubing isn't coiled near the floor, because tubing that's coiled near the floor allows feet to get tangled up in it, and then you can pull that catheter out by accident. So no tubing coiled near the floor. The tubing should be coiled on the bed. Okay. That also helps keep it from being tugged on, from inside the patient. Bags should hang on non-moving parts of the bed. If you're putting this on a part of the bed that moves, like that near the head of the bed, thank you, then as the bed moves, this bag moves, and that can pull on it, cause it to get dislodged. Do you want to see that? Okay. Cause it to get dislodged. So non-moving parts of the bed, super important. Now, this is ways catheters are pulled out. When we turn a patient over in bed, if we trap that tubing between our leg and the mattress as we turn, it can pull the catheter out. So you want to be really careful if a patient has a catheter that you're not holding that tubing with your leg. Transferring a patient to a chair or wheelchair. If you get them out of bed and they have a catheter and that catheter bag does not go with you, you will pull that out all day long. Ambulating a resident. When you stand a patient up from a chair and start to walk them, if you forget that they're attached to a bag, they'll walk right out of that catheter. Absolutely. And our feet get tangled in the tubing near the floor. This is why the tubing cannot hang near the floor. It needs to be coiled on the bed. Confused patients do pull catheters out. And patients do intentionally pull catheters out because it's an irritant. Yeah. So I would question, if we have a competent individual, I would question the need for a catheter. If it's irritating the patient to the point that they're tugging on it or fidgeting with it, then, and we can get the pee out any other way, then maybe a catheter is not a good option. Because when a catheter gets pulled out, remember, if I'm going to remove the catheter, I'm going to deflate this little balloon first. That's the nice thing to do. But if a catheter gets pulled out, this balloon does not get deflated. That means we've got something this big going through an opening this big. You're going to get tissue tearing. You're going to get a little bleeding. You'll get a little urine. It's going to hurt. Now imagine peeing through that. That's like peeing razor blades, because that tissue is all torn and just mangled. So we want to try to prevent having this pulled out whenever possible. That's kind of important. So if we have somebody that's tugging on it, the nurse needs to know, I need to figure out, do we have any other solution here? Any, I'll take any, because I don't want the patient to pull this out. But unfortunately, we pull out way more catheters than patients do. Look at this. There are 4 ways that we pull catheters out. Patients have 2. So we need to be aware of the risks here. Does that make sense? And the 2, patients, confused patients tugging on them, well, we can report that. Patients intentionally pulling it out, they probably let us know that they're irritated with it beforehand. We can report that. So unfortunately, everything on this list, the CNA can do something about. So if a catheter gets pulled out, chances are we didn't do our job somewhere. Does that make sense? It may not be every single case. Remember, change one small thing, one small parameter, you change the whole scenario. So if the patient is fidgety, pulling at it, let the nurse know so that we can remove it. But if a catheter does get pulled out, don't panic. Your patient's going to take their cues from you. If you start panicking, oh my gosh, you pulled your catheter out, oh my God, I mean, they're going to freak out. They're going to think they're dying. They're not. It's just going to burn a little. You need to do a couple of things if a catheter gets pulled out. I really wish my little deck was working here. So here we have a patient who was walking and pulled her catheter out. Does happen. It probably was near the floor and the walker compressed it and pulled it out. So of course the patient's a little upset over this situation. I would be too. But what do we do now? So if the patient pulled this catheter out, or if we did by accident, doesn't really matter. What do we do about it? Well, first, yes, we are. First, I want you to save the catheter and the bag. Leave the whole thing attached and save it. We're going to put it in a bag, but we don't put it in the trash. So we're going to get an empty trash bag and put the whole bag and catheter in that bag. And then we're going to let the nurse know. Now, this bag needs to go somewhere that the nurse can inspect it, because there's a big difference between pulling out a catheter where the bulb is intact and visible and pulling out a catheter where the bulb is missing. There's a big difference there. So now if we are going to document, if we're allowed to use words, remember I said most places don't let us use words. If we're going to use words, your word should say something along this line. Catheter found lying in patient's bed or on the floor, or whatever the case may be. Catheter and balloon intact. That tells us that, okay, well, it got pulled out, but all the pieces are present and accounted for. If we get a catheter that looks like this, so we see it laying on the bed or laying on the floor and it looks like this, no balloon, this is a problem, because both of these have holes. We don't know how much was actually left behind. So here you go. So if you look at that, you can actually see where the, where the balloon actually broke. That's a big problem, because a catheter with a balloon intact, I can work with. That's a nurse problem. I got to figure out, do we want to put another catheter back in, or maybe we can do without? Hi. That's okay. So maybe we can do without, right? So that's going to be something that the nurse and doctor will work together to decide. But if I decide that, yes, we do need a catheter in, we got to work on this now. Because with any injury comes swelling. So I've already got torn tissue. And now we're going to put swelling on top of that. So that may inhibit my ability to actually insert another catheter. Now, if the swelling gets bad enough and the patient can't go, that's a real problem because I'm out of solutions. I have nothing for you. That's going to require some sort of surgery. That's a problem. Big problem. So I've got to figure this out pretty quick. I've only got about a 45-minute window. Once a catheter gets pulled out, I've only got about 45 minutes to figure out, do we want to put another one in? Otherwise, I have no options because the swelling may be so bad that I can't put another one in. So this isn't one of those situations. If the patient's catheter gets pulled out, don't go to lunch and tell the nurse at the end of the shift. I can't do anything now. Okay. And I've actually seen this scenario. So this is along the lines of what you were talking about, right? So a patient's catheter got pulled out. The CNA went to lunch. Totally forgot. And at the end of shift, or near the end of shift, about 45 minutes before shift was over, she went and told the nurse, oh yeah, I forgot. Frank's catheter got pulled out earlier today. And the nurse says, well, how long ago? Oh, I don't know. It was before lunch. And the nurse says, okay, where's the catheter? I don't know. I threw it away. So the nurse has no information to work with now. Now, at the end of the shift, the CNA says, well, I told you that his catheter got pulled out. How come he doesn't have another one in there? So from the CNA standpoint, it looks like nothing's been done about the situation. When in reality, it's a CNA's fault. Nothing can be done about the situation, but the CNA doesn't realize that. And they think it's a nursing problem. So this can set up a you versus them mentality, right? So it's really careful that we try not to get into those types of mindsets where we start accusing, well, you didn't do your job, or I don't think that you're caring for the patient properly, because on both sides, there's things that we just don't know. Does that make sense? Okay. Make sure you save that catheter. Don't put it in a trash bag that already exists. Get a new trash. In the bottom of every trash can in a clinical setting are new bags. You know, there'll be like 3 or 4 new bags. So take the trash bag out, get a new bag, and put the catheter and bag in it. Put it in the patient's bathroom, and then let the nurse know, hey, Henry pulled his catheter out. It's in a bag in the bathroom for you to inspect. Happened 2 minutes ago. And by the way, the bulb looked intact. It was all still there. That makes me super. If I get that report, man, I'm super happy. Super happy with that. Because I've got all the information I need. All right, so let's take a look at this care plan. This care plan tells us to provide catheter care with soap and water to a female resident with an indwelling urinary catheter. Clean the catheter tubing and perineal area only. So, catheter care is going to be cleaning the tubing and the skin around the tubing. Well, we already know that part, peri-care. We go down the middle, side, side, skin fold, skin fold. We already know that part. Cleaning the tubing, we want to hold the tubing where it exits the body so that we're not pulling on it. And we're going to wrap the washcloth around and wipe away from the body. About 4 to 6 inches, which is pretty much the length of the exposed catheter. And we're going to wipe 4 times with 4 different leaves. So we're going to wrap, wipe, fold, wrap, wipe, fold, wrap, wipe, fold, wrap, wipe, fold, or discard. Whatever we wash, we rinse. Whatever we rinse, we dry. So it doesn't matter whether you do Pericare first or catheter. Doesn't matter. Mix them up. Nobody cares. Whatever you want to do. Okay. Getting warm. Now, this care plan tells us provide catheter care with soap and water. This is not going to be the preferred method in every single setting. Some settings are going to have you do this with special medicated wipes that help provide a barrier that keep bacteria from entering the system. You would know what we're using by looking at the policies and procedures that give us that outline for the facility and the care plan, which modifies that for this patient. Right? But this care plan here in this setting for this patient, for the test, this guy only or woman only is going to get soap and water. So when we're doing catheter care, when we're cleaning the catheter itself, we want to make sure that we're holding right there where it exits the body. And this helps prevent us from pulling on the inside. There may be a little ring of protein around where it exits the body. It's like a little raised ring of harder type material that the body deposits there. And the body does that specifically to provide a barrier, something for the bacteria to have, like a roadblock. So you just want to clean around that, but you don't have to chip that off. Okay, does that make sense? We're going to wipe away from the body. That's the big thing here. If you have a written test question that asks you, when performing catheter care, what is an important infection control principle? Wipe away from the body or away from the urethra is what they're looking for. So before I show you catheter care, I want to talk a little bit about drainage bag, emptying the drainage bag, because these two go together. They're two separate skills for the test, but they go together in a clinical setting. So I'm going to show you both of the videos back to back. So turn to page 117 in your skills book for me. And page 117 tells us to measure and record the contents of the urinary drainage bag. We're going to empty the resident's urinary drainage bag into a graduate container and measure and record the urinary output in mLs or cc's on the intake and output form. And this is the intake and output form. You can see it there in the middle of the page. And this is a triangular graduate container. This is what it looks like. It's the same thing. This is just bigger. Same thing. So when you're looking at this, you're going to see ounces on one side and cc's on the other. So ounces and cc's. It's important to note that cc's and mLs are the same thing. cc's and mLs are the same thing. mLs is a liquid measurement. cc's is a volume measurement. In medicine, they're used interchangeably. Okay. So all the test questions you'll see will actually refer to them both, like our care plan said, in cc's or mLs. So we know in medicine that we don't use ounces. We use cc's or mLs. So if you look at this cup, you'll see that it's marked in 50s. So there's a line for 100, 150, 200, 250, 300, 350, and so on. The lines in between are your 25s. So this is 200, that's 225, 250, 275, 300, 325, and so on. You are going to round to the nearest line. Doesn't matter whether it's up or down, the nearest line. So if you have urine in this cup, and the urine stops right there, it is closer to the 375 line. So we're going to call it 375. If the urine stopped right there, it's closer to the, we're not going to call it 362. Okay, you're not that scientific with this cup. This cup only gives us 25 milliliters at a time. You can't like split that. Okay, so I'll pass this around for you to see. Okay, now those of you that are playing along at home, I want to talk to you for a second. All of these supplies that I'm passing around in here, you don't get to touch, feel, see, play with, nothing like that. That's one of the benefits of being in the class. You guys get to actively work with all of this stuff. But you guys can order a practice kit, and all of this stuff is in the practice kit. To go onto my website, so the gate belt, the graduate container, the bag, just like this, everything that you need to practice is in this kit. So those of you who are at home, go buy the kit to help you kind of put your hands on all of this stuff. You guys can come in here and practice with all of the supplies. That's awesome, but only you guys, right? So they can't come in here and practice, which is why I wanted to say that. But some of you won't be able to come in and practice. Some of you will be working or have childcare or transportation. You should also consider a practice kit. And we make it affordable. I charge you the cost of what it takes me to put all these together. So this is your container. This has to be measured a very specific way. Okay, so let's look at the bag real quick. You'll notice that there's markings on the bag too. This is not accurate. This is what we call the eyeball measurement, and it kind of lets us know, is the patient going, about how much are they going, is this kind of normal? But this is not a measurement because it depends on how much it's tilting, if it's folded over. I mean, there's so many variables here. This is rough. This is fine. This is what we're going to record. Even though we have markings here, we don't use them. Does that make sense? It's kind of important. So when you measure the urine, you're going to put a barrier down on the floor, put the cup on the barrier, right? Because we don't want a urine cup on the floor. So put a barrier on the floor, put the cup on the barrier. We're going to empty that bag out of the port, but we're not going to let that port touch anything. Remember we talked about that, right? So this port, we're going to remove it from its house, position it over the cup. We're going to open the port and we're going to empty it. Notice I'm not letting that port touch anything. Not the cup, not the bag, not my glove, not the bed, not the floor, not nothing. And then when we're done, we'll close that back up and we're going to put it back up in its house without letting it touch anything. Now I've got a cup of urine. Can I carry a cup of urine through a room? Open? What do I need? Yeah, I need to cover it somehow. So I'm going to, let me wait for the thing to come back around here. So I'm going to wrap it up in that chucks that was on the floor, take it over to the bathroom, put it on the lid of the toilet on that chucks. because I don't want that cup on the lid of the toilet. Hi. And then I'm going to get down, so it's on a barrier. So we use the barrier to cover it for transport. Once we get it to the bathroom, we're going to uncover it, but leave it on the barrier. And we're going to get down and read it at eye level. At eye level. I can't stand there and do one of these deals. You got to get down at eye level. So that means if this is on the seat of the toilet, I need to get down to read it at eye level. Okay, good. Makes sense? And we're going to round it to the nearest line. Correction, I would not have touched the tubing to anything or the port to anything. You're going to follow your facility guidelines, whatever your facility tells you to do. Sometimes we used to wipe the outside of the port with alcohol, but they found that alcohol, because alcohol dries things, it's a drying agent. So they found that by wiping the port with alcohol, it was actually drying the material out and causing micro cracks to form. And micro cracks can harbor. Yeah. So we found out that even though we thought we were doing a really good thing by removing pathogens, we were actually creating nifty places for them to hide. So you're going to go by your facility policy, whatever they want us to do in that situation. It may be wiping it with a CHG wipe or an alcohol pad, or
Changing the bag.
Yeah, possibly changing the bag. Yep. Right. But again, you're going to go by your facility policy because it's not a one size fits all. It depends on what unit we're on. If we're on just a regular surgical unit and the patient's going to have their catheter removed tomorrow, I'm probably not going to worry about it. If we're on an immunocompromised unit, like a chemo unit, it's going to be a much bigger deal. So what kind of patient population are we working with too? So like I said, we're forming a foundation here, but everything out there is going to vary based on the situation that you're in. Okay. So who should you ask?
Your nurse.
Yep, the nurse. Easy. Okay, so once we've measured and we've dumped and rinsed, remember that urine's going to go in the toilet. You're going to rinse the container, put rinse water in the toilet too. Once we've done all that, now we're ready to document. This is on page 121 of your skills book, but on page 117, you got a small version right in the middle of the page. It's already completed. But we're going to document this under output, not intake. Think about that for a second. If you documented it under intake, what would that mean? Yes, they drank their pee. Please don't document under intake, because trust me, those lawyers would love to see that. So we're going to document under output. It wants the time. Military time is best. If you know military time, that is the way to go. If you don't know military time, in your skills book on page, I think it's 23, 29, I have a whole lesson there on military time for you. But you're going to put the type of output. So in this case, it's urine. Not everything that comes out of the human body is urine. So you have to specify. We're going to put the amount, whatever we measured, and then our initials, and we're going to sign at the bottom. This is the documentation form from the state exam. This is what you're going to document. They're going to give you this form before you ever start the skill. Put it in a place that's visible. So you remember to document at the end. Okay. Questions? Questions? Okay, I'm going to show you these two videos because they have good close-ups. And these are two skills that you need close-ups for. Hi, Miss Jones. My name is Patty. I'm your CNA today. How are you? Good. I need to do catheter care. Is that okay? I'm going to close your curtain, wash my hands, get my supplies, and I'll be right back. Okay, Miss Jones, I'm going to gather my supplies. I'll start out with a barrier that provides a clean place to put my supplies. And we're going to get 4 washcloths, a towel, a chucks, a privacy blanket, and now I'll gather my basin and soap. And a set of gloves. All right, Miss Jones, I'll just get some water. I'll be right back. Okay, would you like to check the water temperature and make sure it's okay? It's good? Good. I'll place the washcloths in there to stay warm. And I'm going to cover you with a privacy blanket. This is going to help protect your privacy and keep you warm while we do this skill. And I'm going to pull your sheet down to about your knees. Okay, Ms. Jones, I'm going to place this pad underneath you. This is going to help keep your bed dry while we do this skill. First, I'll roll it toward me. And place it on the bed. And then I'll put my gloves on. All right, Ms. Jones, can you scoot toward me, please? Thank you. And can you roll onto your left side? 1, 2, 3. Thank you. Going to be very careful, making sure that the catheter tubing rolls with the patient and doesn't get pulled on. I'm going to unroll the chucks underneath the patient's hip.
and have the patient come back onto their back, making sure that they don't lay on that catheter tubing. Ms. Jones, can you scoot to the middle of the bed, please? Thank you. Ms. Jones, can you scoot toward me? Thank you, and roll up onto your right side. 1, 2, 3. And now I can unroll the chucks to protect the bed. Come on back, Ms. Jones, and scoot to the middle of the bed. Thank you very much. Okay, now I'm going to start cleaning the catheter. I'm going to roll your gown up inside the blanket. I will be exposing you, but we'll make this as brief as possible. Please let me know if you're uncomfortable. As I roll the gown in the blanket, I want to make sure that I don't grab the catheter, that we don't cause any unnecessary pulling or stress on that catheter. And now we'll cover her thighs with a towel. This exposes only the area that we're working on. I'm going to take the first washcloth and wring it out and apply soap to 4 leaves. 1, 2, 3, 4. Now I'm going to clean your catheter. I'm going to hold the catheter where it exits the body, wrap the washcloth around, and wipe away from the body. Fold that leaf over. I'm going to hold it, wrap the washcloth around, and wipe away from the body. That's 2. We're going to do this 2 more times. Away from the body. 3. And the last one. 4. I'll set this washcloth aside. Whenever we wash, we must rinse. So I'll wring this washcloth out, and we'll use it to rinse that catheter the same way we washed. I'm going to hold it where it exits the body, wrap the washcloth around, and wipe away from the body. We'll do this 4 times. 2, 3, and 4. Set this aside. Now we'll dry the catheter. Now we're going to do peri-care. We'll take a washcloth out of the basin, wring it out really well. And we're going to soak 5 corners. 1, 2, 3, 4, and the back side is 5. Okay, now I'm going to clean the peri area. I'm going to lift the catheter up out of the way with my pinky and hold the labia open while I clean down the center with the first leaf, always going top to bottom. And then we'll remove the washcloth and fold that leaf over. Now I'm going to clean down one side of the labia, top to bottom, fold that leaf over, clean down the other side of the labia, top to bottom, fold that leaf over. I'm going to clean the skin fold between the groin and the leg, fold that leaf over, and clean the other skin fold between the groin and the leg, and then set that washcloth aside. I'm going to take the final washcloth and wring it out really well, and we're going to rinse all of those areas the same way that we washed them. So I'll fold that catheter out of the way and spread the labia open, cleaning down the center, top to bottom. Fold that leaf over, clean down one side of the labia, fold that leaf over, rinse down the other side of the labia, fold that leaf over. We're going to rinse the skin fold, fold that leaf over, and the other skin fold. Set that aside. Now we'll dry gently by patting dry top to bottom and then removing the towel. Ms. Jones, I'm going to cover you back up. I'll unroll that blanket, which will replace the gown over the patient. I'm going to make sure that the catheter and the tubing is coiled on the bed, not near the floor and not where the patient is laying on it, making sure it's not kinked. Ms. Jones, I'll be right back. I need to dispose of your supplies. The towels and washcloth will be placed in dirty linen. The basin is going to be cleaned the way we clean everything else. We'll return the basin to the drawer, and on the way, we'll pick up the soap. We'll open the drawer with the paper towel and return the basin to its storage area. Now I'll dispose of my paper towels. Okay, Ms. Jones, I need to remove the chucks from under you. Can I get you to scoot toward me, please? Thank you. And can I get you to roll up on your left side? 1, 2, 3. Thank you. I'll roll this soiled chucks toward the patient and tuck it under her hip. Come on back, Ms. Jones. And scoot back to the middle, making sure the patient is not laying on that catheter tubing. Okay, Ms. Jones, can you scoot toward me again, please? Thank you. And roll up on your right side. And I'm going to remove that chucks from the bed. Okay, you can scoot back to the middle. Thank you. This is going to be thrown away. Okay, Ms. Jones, let me just look at your catheter one last time. Make sure that the catheter tubing is coiled on the bed, that the catheter is not on the floor. Everything looks good. I'm going to remove the chucks from the table, and we're going to throw this away. And then I'll remove my gloves. We'll throw those away. Okay, Ms. Jones, I'll pull your sheet up now. And I'll remove the blanket as I do so, rolling it into a ball. You put this in dirty linen. Okay, Ms. Jones, here's your call light. If you should need anything, just let me know. Are you comfortable? Can I get you anything while I'm here, like a magazine? I'm just going to open your curtain and wash my hands. After washing my hands, I'll think about the steps of my skill, make any corrections that need to be made, and then tell the evaluator my skill is done.
Questions? Okay, this one is super short. It's 5 minutes. This is emptying the drainage bag and recording the contents.
Hello, Ms. Jones. My name is Patty. I'm your CNA today. How are you? Great. I need to empty your urinary drainage bag. Is that okay? Okay, I'm going to close your curtain, wash my hands, get my supplies, and I'll be right back. For this skill, I'll need a barrier, which I'll place on the floor under the drainage bag. I'm going to need a set of gloves. And I'm going to need a triangular graduate container. I want to inspect the catheter tubing to make sure that it's coiled on the bed and the patient isn't lying on it and it's not pink, but also that it's not hanging near the floor where somebody might get their feet tangled up in it and trip or accidentally rip the catheter out. This catheter looks like it's in the appropriate position. We'll now remove the port from its protective sleeve on the bag. Sliding the valve to the side will open the port. We can now position this open port over the graduated container and tilt the bag slightly to the side to allow the contents to drain into the graduated container. While doing so, we want to be careful not to allow that port to touch any other surface. Once the urine bag has been emptied, we'll slide the port back to the side to close it and very carefully insert it back into its protective sleeve. We want to make sure that the bag is hanging on a non-movable part of the bed and it's not touching the floor. We can now fold the chucks over the graduate container for safe and secure transport to the patient's bathroom. Once we're at the patient's bathroom, we're going to set the graduate container down on a barrier on a flat surface and position it so that we can read it. We need to be at eye level, and we're going to round to the nearest line, either up or down. You can see that the urine in this container is nearest to the mark of 425, so the amount that we will document is 425 milliliters or cc's. Once we've measured it on a barrier on a flat surface at eye level, we can now empty the urinary graduate container. We'll throw the barrier away, open up the toilet, and we're going to dump the contents of the graduate container into the toilet. Now we're going to rinse the graduate container. We'll deposit the rinse water into the toilet as well. Now we can clean. After dumping the rinse water into the toilet, we'll set it down, use a paper towel to pick it up, paper towel to dry the outside, paper towel to dry the inside. We'll discard this, and then one for the door. We're going to place the graduate container in the bottom drawer and close the drawer with a paper towel. Okay, now I'll throw the paper towels away and remove my gloves. We'll throw those away as well. Thank you very much, Miss Jones. Is there anything else I can get for you while I'm here? A magazine, perhaps? You have your call light there. If you should need anything at all, please feel free to let me know. I'm going to open your curtain, wash my hands, and document my skill. Thank you. After washing my hands, I'll document on the intake and output sheet that the evaluator gives me. I'm going to document the time of output, the type of output, which is urine, the amount of output in cc's, and my initials. After documenting, I'll review the steps of my skill, make any corrections, and then tell the evaluator my skill is done.
Yes. Yeah, this, remember I said that that's a new feature, so the, videos aren't going to play. Okay, so any questions on those two skills? You are now done with the skills. They're all done. And what you learned today should have been pretty easy to learn because it's all variations of something that we've gone over before. Nothing today was very new. Before I give you, I'm going to give you the review sheet for just a few minutes, and then we'll take a break, and then we'll have some practice time. But I do want to review a few things with you. How do we know what to do with each patient? Care plan. The care plan. We follow the care plan, the whole care plan, and that means we can't change it. So I want to stop there for just a second, because what we focus on in this class is skills. I've gone over some theory with you as well. You've learned a lot of the principles you're going to need for the written test, but this is one of those written test concepts. When you're reading a question on the written test, and we've talked about this a lot in this class, but when you're reading the question, if you change anything in that question, it changes the entire question. Right? Remember, any parameter changes the whole scenario, right? So if you have a question that says, your patient who has Parkinson's enjoys their hot coffee in the morning, but their shaking is getting worse and you're concerned about burns. What is an appropriate action? I don't want your brain to think, well, if, and change the question. The question is what it is. You don't get to change it at all. So you can't think, well, maybe they would like iced coffee. Question says they enjoy hot coffee. The question is the question. It doesn't change. So be really, really careful, because your brain it's gonna want to try to change those written questions on you. It'll add something in, it'll change your brain will do all kinds of really funky things on you if you're not aware of this, if you don't work hard against it. The question is the question, don't change any of the parameters or it changes the whole scenario. Does that make sense? So that's where the care plan, the whole care plan, and nothing but the care plan comes in. It goes with the written question as well. Don't change the written question. If we make an observation while we're following that care plan, if we notice, I forgot hold on. Sorry, guys. If we make an observation, if we notice anything, what do we do with that information? Tell the nurse. Okay. So now that we have our tasks that we're going to do, we know what we're going to do. We know how we're going to do it because care plan told us. How do we start doing it? What does every skill start with? Okay, every opening starts with a knock. So you're going to knock before you enter the room. Once you enter the room, what do you need to find out? Okay, who you're working with, right? Who is this person laying in the bed? And don't think that just because it's supposed to be John Smith, that it's actually John Smith. Because patients a lot of times will play musical beds. Like John Smith goes to X-ray and Robert Morgan climbs in the bed because he's confused. And all the rooms look alike. You know, he thinks he's in his room, but he is not. So you have to find out who the patient is. Once we know, well, not necessarily, because our mans can be wrong. The best way to identify a patient is through them specifically. ID bands can be used as a secondary, but not a primary. Once we know who we're working with, what do they need to know about us? Who we are, name and title. And then we're going to explain what we're doing. That doesn't end at the opening, though. I do want to make that clear. I don't know if I made that clear. Talking to the patient, telling them every step of the way what you're doing does not end at the opening. You're not going to walk in and say, okay, I need to do some exercises on your left or your right hip, knee, and ankle. Is that okay? They say yes, and then you don't have to talk to them again. Right? So when you're in there actually doing the exercise, you've got to give them information every step of the way, because otherwise they're not going to be compliant. If I'm going to put my hands on your bare leg, specifically your bare thigh, I better have a really good reason for being there. Or you might make one up for me. Right? So when I'm going to lift that leg up, I want to let them know, okay, I'm going to lift your leg up and we're going to bend the knee to your chest and back down to the bed. We'll do this 3 times. I want them to know what I'm doing every step of the way. I'm talking out my skills. It doesn't end at the opening. Okay, that's how we get compliant patients. So we're going to bend, we're going to we're going to let them know what we're doing because we need to get what from them? Permission, consent. And then once we get that, we'll close the curtain. And what do we do after we touch that curtain? Wash our hands. We're going to get some supplies. What's the very first supply we should go get? The barrier. Very first thing. Don't try to juggle everything. Barrier first. Put it on the table. Which side goes up? Yeah, the absorbent side. Yep. Yep. So we're going to put the barrier on the table, absorbent side up, and then we'll go get the rest of the supplies. When we're getting our supplies, what should they not touch? The uniform. So we're going to go get the supplies, hold them away from you, put them on the table. If we have to get water for whatever reason, right? We got all of our supplies. We're going to go fill a basin up with water. Can I touch that sink faucet? What do I need? Okay, so I'm going to use a paper towel, turn the water on. So just cold water? Warm water. Hot water? I like hot. Hot water? Warm water.
just because I think it's okay, and I'll check it with the inside of my wrist because that's the best place for me to check it. Just because I think it's okay, will my patient always agree? How do I know? Ask them. Very good. Okay, so I've got some water now for my bathing, got all my supplies and all of that. How do I know if I need gloves? Should I just wear gloves for everything because it's healthcare? You sure? Good. Very good. So how do I know when I need gloves? Okay, personal skin, ooey gooey, open skin, broken skin, non-intact skin. Yep. Okay. So if any of those, if I'm looking at my patient, thinking about my skill, and I think to myself, there's no ooey gooey, there's no open skin, there's no personal skin, do I need gloves? If the answer to any of those is maybe, do I need gloves? If the answer to any of those is yes, do I need gloves? Yes. Okay. So if I decide to wear gloves, should I put them on right away? When should I put them on? Okay, after I've washed my hands. Okay, so I've done all of my prep work. First thing your gloves should touch is the patient. Do all of your prep work first. What if the patient is going to be uncovered or undressed during this skill? Need a privacy blanket. Isn't the curtain enough? Why? Yep. So it's more than just privacy. It's temperature, and we're strangers. We're in the space with them. Absolutely. So privacy becomes important. Should I put the privacy blanket on before I put my gloves on? What's the first thing my gloves should touch? So should I put the privacy blanket on before I start this, or with gloves on?
No, not with the gloves on, before you put the.
Okay, so before I put the gloves on, that way, and that's the appropriate way to do it. We're going to put our privacy blanket on, pull the sheet down underneath before we put our gloves on, because remember, all of that would contaminate the gloves. That's right. That's right. So remember to get that order right. Okay. When I'm putting a privacy blanket on, what should I be careful not to do with it? Shake it or snap it. Very good. Okay. Once I've done my skill, touch the patient, my gloves are dirty. I have to be careful what I'm touching with those dirty gloves. Dirty gloves can touch dirty things, but dirty gloves cannot touch clean items. So I need to take those gloves off before I put the sheet up next to their face, before I give them the call light, before I touch the curtain. Even though these things are not considered clean, we don't want to make them any dirtier. Right? Does that make sense? Okay. All right. So what if I take, so I'm getting supplies, and what if I accidentally take too many? What do I do? They go, yeah, we can't reuse them. We can't save them for later. You can't let them hang out. Use them or lose them. Okay. What if I need to turn a patient over in bed? Where should the patient always be? In the middle of the bed, always, right in the middle of the bed. So it doesn't matter if they're on their back or on their side, they need to be in the middle. Why can't I just use side rails to keep them safe?
That's a restraint.
They are considered a restraint. We have to have a doctor's order. Very good. All right. When I'm washing something, whatever I wash, whatever I rinse, I dry. Okay. We want to try to keep our surface dry, so put something, like if I'm working on the table, I need a berry on the table. If I'm working on the floor, I need a berry on the floor. If I'm working in the bed, I need a towel or something in the bed just to keep my surface dry. If I'm going to put lotion anywhere, what do I need to do before I put the lotion on? Please warm it. Please warm it. I love my husband dearly, but when I get a back rub from him, he squirts cold lotion right on my skin, and that is not relaxing in any universe. Please warm the lotion. But once we put it on, what do we need to do after that? You've got to wipe that excess off because otherwise it's a safety hazard. If we're going to wash a basin, any basin for any reason, they're all done exactly the same. How do I know where to put the contents of the basin? So whatever's in the basin, whether it's water or urine or whatever. Okay, where it normally goes. Yeah. So when you look at it, where does this normally go? If it's water, where does water normally go? If it's urine, where does urine normally go? Please don't get those confused. Okay. And then we'll rinse it and we'll dump the rinse water wherever we dump the stuff, right? So where if we use the toilet, then we're going to dump the rinse water in the toilet. And then we're going to dry and store. But if we're going to store it, what do we need to open the drawer? Paper towel, because your hands or gloves are not clean. If we are doing any sort of mobility skills, so walking or transferring or anything like that, if the patient's feet hit the floor, what do we have to talk about? Shoes. They've got to have them on. If they don't have them on, what are we going to do? Put them on. Don't ignore it. So this brings me to something really quickly. The way you practice is the way you're going to perform the skills on the test. So if you're taking shortcuts in your practice, you're going to forget to do important steps on the test. And this happens to students all the time. They'll be in here practicing. So let's say that you two are working with transferring, right? And you're going to transfer her into a wheelchair and she's got shoes on and you just don't feel like worrying with it. So you say, just leave your shoes on, I'll remember. And you do the whole skill without physically putting shoes on. When you go take the test, you'll forget to put shoes on. Same thing with gloves. I see students all the time in here practicing without gloves. Oh, well, I'll wear them for the test. I just don't want to use your supplies. Guys, you paid the money, use the supplies. Okay. I'm telling you, use it. Don't go out there and sell them on the black market, but use them while you're here, because what happens is if you get used to like simulating mouth care without gloves, your brain will say, it's completely normal for you to have your hand around somebody else's face without gloves on. That will look normal to you. And you'll forget to put them on in the test. Where if you start from the beginning wearing gloves, even if you're simulating mouth care, practicing on each other, whatever, your brain will associate hand by face, glove. Does that make sense? The way you practice is the way you'll perform on the test. Don't take shortcuts. Super important. All right, so if we know that slipper socks aren't enough and we're going to talk about their shoes, let's talk about what position their feet should be in before we stand them up. Where should their feet be? Flat on the floor. And you want to ask them, are your feet flat on the floor? You need to, before you stand somebody up, you need to give them a cue of some kind. What is a cue we can use before we stand them? Count to 3. 1, 2, 3. And we're going to stand. If we're going to use a gait belt to help somebody stand, particularly because our care plan told us to, so we know that's important, we're going to put it on. How do we know it's tight enough? 4 fingers. So you want to make sure that it's tight enough, because we get skinnier when we stand, that gait belt will get loose. So check it with 4 fingers, and you want to do that out loud. 4 fingers. You want to say it. When you're going to stand somebody, you want their hands on your shoulders so that they're moving as a unit. If you just let their arms stay at their sides when you're trying to lift somebody, their shoulders will automatically drag backwards. You aren't lifting them as a unit. You're lifting here, and that's going to throw them off balance. So in order to get them moving as a unit, have them put their hands on your shoulders as you're lifting, and that keeps them in one unit. You can actually see this. I forgot to show you this, I think. Let's go to ambulate. Turn to page 45. On page 45, at the top of the second column, you can actually see a video clip. I actually pulled this off of a video that's on YouTube right now to show you the position the patient is in if their arms are not on your shoulders. See how their shoulders are kind of backwards? This is going to put that patient off balance and much more likely to fall. Good? Okay. So what does the patient have to feel before we sit them down? Yep, they've got to feel the chair against the backs of their knees. They have to. You've got to verbally say something about that. So when we're sitting somebody down or standing them up, should we be directly in front of them? What do you guys think? Directly in front of them or at an angle? At an angle, it makes you much more sturdy, less likely to fall. Okay, at an oblique angle. Remember, 1 foot in front of their feet and 1 foot to the side. When you're doing range of motion and you're moving a body part, remember we're going to move slow and smooth and always return back to start for a full range of motion. We're going to explain every exercise in a way that they can understand. If we're going to dress a resident that has a weak arm, which arm do we undress first? Right? Undress strong arm first, dress weak arm first. If we're transferring somebody into a wheelchair, what important safety step do we need? Lock the wheelchair when you're taking somebody out of it, when you're putting somebody in it, or when it's not in motion. We want to make sure their feet are on the foot pedals. Very good. Very good. What position does somebody need to be in for mouth care? Okay. If we're going to do denture care, how do we protect the dentures? Washcloth in the sink. Very good. To clean the mouth the dentures came out of, we're going to use something different than a toothbrush. What are we using? Toothette or oral swab. Very good. Let's see here. When we're feeding a resident and they say, I'm done, I'm finished, I'm full, whatever, what are we going to do? Celebrate or?
We're going to try to get them to eat one more bite.
Okay, so we're going to encourage them to continue eating. We're ideally 2 ways. When you're counting respirations, what do you not want to tell the patient? That you're counting respirations. Very good. Very good. And what is a normal pulse rate? 60 to 100. What's a normal respiration rate? 12 to 20. Very good. Very good. For bedpan, what is the most important step of bedpan? Yeah, head of the bed up. Yep. Chuck's important because of sloshing. Gloves important because of butt juice. But if you don't get the head of the bed up, none of that matters. Yep, none of that matters. Okay. Foot care. What is the main purpose of foot care? Is it, to get rid of stinky feet or observation? Take a look at that skin. That is why you were there. So for the test, what do you need to do? Look at the skin and say you're looking at the skin. Let them know. Absolutely. Yep. Yep. Let me see here. Partial bed bath. Long care plan. That is the longest skill we do, right? 19 minutes, partial bed bath. But when we're cleaning the face, we're going to use something specific, a specific method to clean the face. Anybody know what that method is? Okay, only water and leaves. Why? Why do we need to use leaves? Body openings, because remember the doorways in and doorways out. So we're going to wipe one eye, and because it's a body opening, we'll fold that over and then wipe the other eye. So anytime we're washing a wet body opening, we need the leaves method. When we're washing anything, make sure you wring those washcloths out because we don't want drippy wet washcloths anywhere. And what would, if we were a little slow because it's the test and we're new and we're kind of unsure and we notice the water gets cold, what do you want to do? Do you just ignore it? Yeah, so absolutely get some warm water. If you notice that this is taking a while and when you put your hands in to wring out that washcloth, it feels cold to you, it's definitely going to feel cold to the patient. Absolutely. So Pericare, I want to talk about real quick because I did not cover this, and this kind of goes with catheter care as well. This is probably the most important time to explain to your patient what you're doing. Don't just grab the blanket and move it out of the way unless they know why you're uncovering them. Because you may have told them, okay, Miss Jones, I'm going to do Pericare. And she may have said, okay, but has absolutely no idea what you're doing. Yeah, she's just agreeable because she's an agreeable type of person, knows you got a job to do what you need to do, whatever. And then you walk in and you expose her. Is she comfortable with that? Probably not. So it's important that you let them know, I'm going to roll this blanket up. This is going to expose you, but I'll be as brief as possible. Let me know if you get uncomfortable. That's very reassuring to the patient. They don't feel like they're being violated. So you've got to talk to your patients, not just for Pericare, but also for catheter care. If you are anywhere in their no-no square, they need to know why you're there and you don't want to be caught sightseeing. Okay, that's not what we're doing here. We want to maintain integrity as well. Anything you see or smell or feel is shared with the nurse and the nurse alone. If you go on break afterwards and you've got a whole bunch of CNAs sitting out there and you're gossiping about so-and-so's whatchamacallits, you are not employing integrity. It's a HIPAA violation, but it's also just a basic human rights violation. Now, the reason I bring this up is because this happens way more often than I would like it to. At least once a year, somewhere, somebody has a cell phone in a personal belongings bag on the bottom of a table or a stretcher, and their voice recording or voicemail is recording or something, and they hear people in a surgery setting talking about body parts that have no bearing on the surgery that's being performed. Integrity. We need to maintain, because that reflects bad on all. Can you imagine? I want you to think for a second. You go in for skin cancer surgery on your shoulder. And when you wake up from surgery and you're in recovery and you grab your phone to, text your loved ones, I made it out okay. And you see that your phone recorded something and you start listening to it and you realize that they're talking about your body, not your skin cancer, not things that are related to why you're there. They're talking about the size of your whatever. How likely are you to trust anyone in medicine again?
Not very.
Integrity. It affects all of us. All of us. So do the right thing even when no one's looking. And if somebody else in your orbit is making those comments, you do not need to cooperate. If somebody said to me, oh my gosh, did you see the size of his? Stop. That's not appropriate. Yeah, that is not appropriate. So I'm going to stop that conversation right now. I do not want any part of it. Yeah, that's right. This has no bearing. But, these HIPAA laws exist for a reason. Why do they exist? Yeah, because we can't police ourselves very well. So now we got to have an outside agency police us. That's horrible. Healthcare workers are supposed to have the highest level of integrity. Where did we fall? we need to be aware and police ourselves a little bit more effectively. Okay. That's where part of that privacy blanket issue comes in. Super important. All right. And then with drainage bag, what is the one thing that port, what is one thing we have to remember about that port? Can't touch anything. And remember that you have to measure on a barrier, on a flat surface at eye level. All three of those things are on one checkpoint line. So if you miss one, you miss them all. Good?
So, you know how like in the facilities, like you normally like raise the bed up a little bit, that way the hose doesn't touch the floor. You drain it into the little container, so basically you like pick it back up and everything before you pick it up, put it on something eye level.
So you're going to empty the bag. You don't want to measure it on a bedside table. You want to take it to the bathroom to measure it. So you're going to wrap the chucks around it, but make sure the port is put away on the bag before you leave the bedside. Now, after you're done with everything, you can put the bed back down before you leave. That would be part of your closing. Okay. Good. Great job, guys. So you've just shown me that you have learned everything that we have gone over in class. These review sheets that I've been giving you at the end of every class are great reviews for the state exam. So right before you go into test, like when you're out in your car waiting for your turn, you should be reading over all of these to remind yourself of those little sayings. You'll hear me in your head when you go test. You will. Sure. If you guys need any, if you're missing any of the review sheets, let me know and I'll get you what you need. Okay, does anyone have any final questions for me? We're going to take a break. The rest of the class will be practice. So those of you that are joining us from YouTube land, you will be dismissed for the day. I'm going to shut the camera off for practice. But you can take a little break before. Remember on Wednesday, you need to bring your blue book in. White book is yours forever. But bring your blue book back to me, and we are going to take a class photo. I'm also going to talk to you about what to do after the test, how to renew your certification, how to find a job. We're going to go over some interview tips. I'm not done with you yet. I mean, we're done with skills, but I'm not done with you. I still have some things to go over with you, but you will have some practice time on Wednesday as well. Okay? All right, go ahead and go on break.